Hi, everyone, and welcome to the 60-second episode of Vitals and Voices. I'm Lathika, and I'm the founder and host. Vitals and Voices brings together people with different experiences in healthcare to share their stories with the world. Now, please welcome our guest, Dr. Goldstein.
Thank you. Thank you very much.
Of course. Thank you so much for joining us today. We're truly grateful to have you on Battles and Voices. To start us off, could you please introduce yourself and share a little bit about your background and the work that you do currently?
Sure. So, my name's Steve Goldstein. I am a tenured professor at the New York University Grossman School of Medicine here in New York City. Background: I grew up in a town called Passaic, New Jersey, 10 miles from New York City, although none of my friends' fathers got on a train and worked in New York. They were all doctors, lawyers, and merchants. It's an interesting town to be from. Anyway, I went to Colgate University in upstate New York and then did medical school at New York University in New York City. Did a 1 year internship at Parkland Memorial Hospital in Dallas, Texas, famous for where not Dr. John Kennedy was born when he was shot. And then finished a residency in obstetrics and gynecology at NYU and have been on the faculty ever since, having risen through the ranks to become a full professor with tenure, and I'm still there. Um, I actually have the best job in America. I really do. I, I will do this until they carry me out in a body bag. I just have so much fun. I have great patience, but I also get to do all kinds of fun, other academic things. I've written 2 books for lay people, 7 medical textbooks. Wrote the second book ever on vaginal ultrasound sonograms that go into the vagina. Spent much of the early part of my career teaching the world how to do those kinds of technology because the world didn't know really how to do it. And uh, have been involved in a number of societies. I've been president of what's known as the American Institute of Ultrasound in Medicine. And then about halfway through my career, I kind of morphed into perimenopause and menopause. And I've been president of what was the North American Menopause Society. They've renamed it the Menopause Society. And then more recently, I was president of the International Menopause Society. Uh, I like, I guess, societies, and it's given me an opportunity to travel and speak, and yet I'm still a full professor with tenure at NYU. I lecture medical students. I'm the representative from our department to what's called faculty council. I chair what's called the Grand Rounds Committee. Every Tuesday afternoon, we have a special lecture, and I kind of organize and coordinate that process. I'm on the executive portion of the mentor-mentee situation for our faculty. And my patients are great, and I love problem solving. So uh, I love going to work.
Love it. And of course, you sound like a really accomplished person. So, congratulations on all those milestones. Yeah, of
Thank you.
course.
Thank
So, diving deep into your childhood, you shared that you wanted to become a doctor from a very young age. What early experiences kind of influenced that decision for you?
Well, so literally when I was in the first grade, I know that sounds kind of bizarre. I have an older brother. He actually just retired. He was an internist, internal medicine doctor. When he was in the 5th grade, there was a Dr. Thomas Dooley who maintained the jungle hospital in what was then Laos. I guess that's now Cambodia. And he came to visit that 5th grade class in Passaic, New Jersey. I think he knew the teacher. And I can remember we went door to door collecting soap and toothbrushes because that's what he said he needed the most for his jungle hospital. Uh, and went with my brother and his friends who were in the 5th grade. I was in the first grade. It was my first lesson. When a lot of people when you ask for soap and toothbrushes, they just gave you $1 or 2. And so when we went to the supermarket to buy the soap and toothbrushes, it was the first lesson I ever had that you could buy that brand. You got 4 bars for $1, but that brand you only got 3 bars for $1. So it was a real economics lesson as well. We actually boxed this stuff up, took it to the post office, and mailed it off to Southeast Asia. And for the longest time, I wanted to be a doctor. I thought I was going to go to Southeast Asia. That kind of fell by the wayside. But I was good in math and science, and I kind of always did what my older brother did. You know, he was a debater, I was a debater. He played tennis, I played tennis. But it worked out. I became a doctor. In fact, one of the first things I ever did that he didn't do was went to NYU Medical School because he had gone to George Washington, the same college he did. Uh, but then he went into internal medicine. It was a time when most of my friends who were very, very smart went into internal medicine, but my experience at NYU at Bellevue Hospital on internal medicine, I realized that most of what you do is you take care of relatively people with chronic disease and you manage their disease. If they have diabetes, they have lupus, they have rheumatoid arthritis. Um, Obstetrics and gynecology is a great field. It's mostly young, healthy people. Often two people come to the hospital, but after the birth, three people go home. It's almost always happy. Very few people die, except for miscarriage occasionally. It's it's an upbeat field. It's a surgical field, but you're not a general surgeon. It's all women, but that's you get to deal with husbands. So I gravitated towards that and have never regretted it. It's been a wonderful career for me.
That's so amazing again, and congratulations on that. And it's just so amazing how you've like had that passion ever since first grade. So, yeah. So, your career has spanned clinical care, teaching, and leadership. So, how have those roles shaped one another over time?
Well, it's interesting how much fortuity sometimes enters into life choices and life decisions. In the third year of well, let me rephrase that. So there's a thing called the matching program in medicine, where when you're last year of medical school, you rank all the places you'd like to be a resident, and they get to rank their people in order, and you get matched with a computer to the highest one on your list that has room for you. And so NYU was a pretty good program, but at the time I was graduating, Parkland Hospital in Dallas was really the home of the textbook of obstetrics called Williams. It was really one of the premier programs in the country. And I think I only got in there based on some good recommendations from people at NYU. So I went to Dallas, Texas for a year, and after about 3 months, was not very happy at all. I was on some rotations that I didn't really enjoy, and I called up the doctor at NYU who ran the residency program and asked if there were knew of any openings back in New York. And he said, "Oh, actually, we're going to have one. We'd love to have you." So by less than halfway through my year, it was all arranged for me to come back to New York. Although by three-quarters of the way through the year, I wondered why was I leaving. I started to like it a lot better, but it was all a done deal. So I came back to NYU. And at the end of my third year of a 4-year residency, I had a thing in my eyes called keratoconus, where my corneas were cone-shaped instead of spherical. And I had to have cornea transplants. And I had to take a leave of absence for a year. And they were so good to me because there used to be 8 residents at each level. And when I was gone, time to come back, they just let me come right back as a fourth-year resident. But now there were 9. So instead of having 8 45-day rotations, they made 9 40-day rotations. So everybody got one 40-day elective. So for my elective, I thought, well, I want to go back to Dallas and see some of my friends and kind of not work so hard as you do when you're a resident. But because I had kind of left them, there were 10 residents at Parkland, and 4 of them left after 1 year. So they weren't all that happy. I'm thinking, who can I call up with a straight face and kind of like ask to come do an elective? And there was a doctor there named Dr. Santos, who ran an ultrasound lab. This was 1979. Ultrasound sonograms really were not very well developed yet. They really weren't doing them at NYU. And he had a facility in Texas where they did them. And I said, Dr. Santos, can I come work with you? And he said, Oh, yes, Dr. Goldstein, I remember you. And so I went there and I thought I was going to sort of play for 6 weeks, and I ended up falling in love with ultrasound. So when I came back to NYU and finished up, the chairman there was very nice. He used to give people maybe 3 half-day clinics at our Bellevue facility to make some income while your practice got off the ground. And he let me do 2 of my 3 half days in the radiology department at Bellevue doing ultrasound. So that's how I sort of developed this interest in ultrasound. And then when the equipment for vaginal probes, these probes that go into the vagina that can image the uterus and ovaries in much closer proximity and more detail, when they came along, I got my hands on some equipment, published an article or two, and sort of started to create this subspecialty. And then I wrote a book, second book ever on the subject in the mid 80s. Uh, and and then what happened was interesting. The guy who wrote the first book, 6 months ahead of mine, was at Columbia. I was at NYU, both in New York City. Instead of becoming competitive, we became friends. And then we published books together on gynecologic ultrasound, which had never been done before. We taught courses together. And actually, in 1996, I recruited him. He came from Columbia to NYU. And we've been great friends ever since. He just retired about a year ago, a little older than I was. And that's how my career in ultrasound took off. I made a number of what we call clinical observations. In 1989, I was the first one to suggest that a simple cyst on the ovary in women who were menopausal uh, was maybe not malignant. And previously, these women all got surgery. We had 26 cases in a row, who all got operated on. Not one was malignant or borderline malignant. So he said, maybe we shouldn't be operating on everybody. Maybe we could watch them more carefully. That was 1989. By 2009, and I can't tell you how many thousands of women got operated on, um, the American College of OB/GYN finally said, you know what? If it doesn't have any solid areas and it doesn't have any blood flow, leave them alone up to 7 centimeters. We were the first ones to suggest that. In 1990, I was the first one to suggest that if women who were menopausal had bleeding, which can be a sign of cancer, if their lining of their uterus on ultrasound was thin, and in those days we used 5 millimeters as a cutoff, there really wasn't any tissue there. Well, that was just based on 30 patients. I didn't expect them to jump on that as the standard of care. But then when literally several thousand women, mostly out of Western Europe, who had bleeding were studied, by 2009, American College of OB/GYN finally said, you know what? If they have bleeding and their lining is 4 millimeters or less, they don't need a biopsy. They don't need anything else. That's good enough. I was the first one to suggest that. In fact, about 4 years ago, I got a gold medal from the International Society of Ultrasound in OB/GYN for contributions I'd made to the field. And the Ian Donald Gold Medal is supposed to go to someone whose work has changed the way medicine is practiced. So I was very proud of being an Ian Donald Gold Medal winner. There's been 34, I think, since the society started, and most of them have been in obstetrical ultrasound. Only 2 or 3 have been in gynecologic ultrasound, which mine was. So it was interesting. If I hadn't needed that eye surgery and I hadn't gone back to Texas and I hadn't thought I was going to have a really easy, fun elective, a whole new career took off, you know. And then as another aside, it's interesting. So when I first went into practice, I finished my residency that year later, um, and that head of the department had given me those 3 half-day clinics that I told you about. You know, and I had a small private practice. I was renting some office space from a doctor on Park Avenue and 78th Street. I was a Park Avenue doctor for 9 months. But there was an opening in what was called faculty practice at the medical center. And they invited me in, I think mainly because they used to split the expenses by 14 slots that they had. And with there being an empty, there were only 13 people. So they needed a warm body to share in the expenses. But it was interesting because that same head of the department, I don't know if he ever really thought that highly of me, because all of my peers who were my generation in that faculty practice were assistant professors with an opportunity, what was called the tenure track. And when they invited me to practice in that facility, I was a clinical assistant professor. I was not on the tenure track. And then when that chairman became ill and he retired, his underling, who became the acting chairman, I think appreciated some of the work that I was beginning to do in ultrasound. And he gave me a chance to be on the tenure track. And of all of those peers, I'm the only one who progressed to become a tenured full professor. The rest of them kind of fell by the wayside and never got past clinical associate professor. And I think, it wasn't conscious at the time, but I kind of think that because that particular doctor, his name was Gordon Douglas, didn't think that highly of me, that maybe that motivated me to become an overachiever. I don't know. Uh, I wonder sometimes, but he didn't think that highly of me, and I'm the only one of that entire generation who progressed.
That is honestly so amazing again, and congratulations. Like, you are, I don't know how to explain it, but you are just a really accomplished person, and you are really a great role model for teens like me. So, yeah. And I really love how you were able to kind of work with that other fellow doctor to research more in the specialty that you're currently in. And I kind of really appreciate how you described how those two roles influence one another. I think it makes medicine feel more holistic. And so you've been a leader in medical imaging. So what are your thoughts on how imaging technology should be used responsibly in modern healthcare?
If I can, before we get to that, and I think
Mhm.
that I'm very passionate about that, but you mentioned the word holistic, and I've got some insights. Our residents now, when they present a case, they can't seem to present a case without somehow working in the phrase with shared decision making. We did blah, 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 blah. They have to understand, your generation, you're young, but
Mhm.
when I was your age, when you went to the doctor, if the doctor said, do this, you did that. You didn't ask them why, what's the evidence? Is there an alternative? You know, he or she was the doctor and they knew best. You just followed what they said. It's interesting. I feel like my entire career, I have done what I call shared decision making. I find myself really spending time trying to educate people because at least several times a day, I will say to a patient, I really like you. But when you leave, I'm moving on to the next patient. I said, so if you don't understand what we're doing and why we're doing it or what the plan is, how can you participate in the process? Uh, and those are I think it becomes somewhat self-selecting because most of my patients, that's what they want. I think that's why they end up in my office. I think that's why they come back for 3 decades and bring their daughters and their mothers and their sisters. But I am shocked at how many people of different ages, different socioeconomic backgrounds, different levels of education don't necessarily want to know. It's like, well, she's the doctor or he's the doctor, and she said, do this. And well, they went to Dartmouth and Harvard, and they're affiliated with Mount Sinai. So, God, they must be great. It's never been me, and I don't seem to attract those people. I don't really want or need those people. I like patients who want to partner with you. Um, I spend a lot of time educating. I'm really just an educator, I think. Uh, but I spend a lot of time educating because, as I said, there are still doctors out there that, don't worry, dear, I'll take care of it. It's not my style. And that's probably a good lesson for your listeners, whether they're interested in going into medicine or if they're going to be medical consumers. They should always want to know, why are you recommending that? And the other thing that I find that's happening a little too often, uh, big buzzword is evidence-based medicine. In other words, there should be science and evidence behind decisions that we make. But all too often, societies will release what are called guidelines. And guidelines often consists of clinical pathways or what are known as algorithms. If A, we do this, and B, we do that, and there'll be like decision trees. And those kinds of things work very, very well for populations, but they don't always work perfectly for an individual. And so when I lecture to the medical students, I always say to them, guidelines are great, but you should always be thinking about who might the outlier be? Who might you want to think about? Does the guideline apply to this particular patient? The ability to think and individualize and combine some judgment and experience with the evidence and the guidelines, I think are the mark of a really good physician. Now, your question was about imaging. So, because I developed this vaginal ultrasound, and I really hoped as this was growing up that it would be part of every pelvic exam. For years, I don't know if you realize that what gynecologists did was they put two fingers in the vagina, one hand on the abdomen, and they would palpate the abdominal and pelvic contents. Was the uterus normal size? Was it enlarged? Is this ovary normal? Is it enlarged? It might have a cyst in it. Is there tenderness? Is there normal, what we call mobility to the pelvic organs? My concept has been you can replace much of that objective information with an image in a matter of seconds if you have the equipment and the know-how. And I honestly believed when this was first introduced more than 30 years ago, that someday every exam would have ultrasound enhancement. That has not happened. If anything, there was an article that from 2003 to 2019, the number of vaginal sonograms that graduating residents in OBGYN did fell 50%. It wasn't going up, it fell. And you wonder why. It's because in 2003, they instituted these things called the work hours rules. There was a tragic outcome at Cornell here in New York where an author named Sidney Zion's daughter Libby died in the Cornell emergency room, and it was attributed to the fatigue and mistakes of the intern and resident. In the following year, they instituted these rules that interns can work no more than 60 hours a week, residents no more than 80. If they work a 24-hour shift, they get a whole day off. Years and years ago, you worked many, many more hours. And yes, there was a fatigue factor, but there was also a continuity of care. As they have shortened the hours, they haven't increased the number of years. And so what I see happening is many of the young people who enter my field are struggling to learn complicated deliveries and C-sections, minimally invasive surgery, sick people in the hospital, such that things like ultrasound or hormones, menopause, osteoporosis, I used to say it's on the back burner. I fear it's not even on the stove. And this, I think, is getting worse and not better. So I don't see that the rank and file are getting the kind of training in their ability to do this kind of pelvic imaging, which is really what I'm talking about primarily, and we can expand it in a minute. So it's an interesting thing that in my office, every patient who has an exam will have it ultrasound enhanced. But I'm doing this myself. I don't have a sonographer or a technician. I'm not sending them to radiology to get a scan, which then generates a report. I'm doing this and incorporating the information into the synthesis of what we're going to do next. I'm on the program committee for the World Congress for the International Menopause Society that'll be in Rio this fall. And the chair of that committee is actually from Spain. And he said, we should have a debate that all women should have a vaginal sonogram, thinking that I would be the affirmative. And I said, well, it may seem hypocritical because I do it, but I don't advise it. He looked at me, what do you mean? And I said, well, because if every woman had a scan, the number of unnecessary MRIs or unnecessary surgeries would go through the roof. There are the kind of ultrasound that I do, I coined a phrase called sonomicroscopy. It's like we're doing ultrasound through a low power microscope. I am seeing things with ultrasound that you could not see with your naked eye if you could hold the structure in your hand at arm's length and squint at it. You have to know the difference between innocuous and common and ominous. For instance, I have a cyst in my kidney, a cyst in my liver, and a benign growth in the right lower lobe of my lung, none of which were discovered because I was having a problem, none of which need to be dealt with. Uh, 1 out of 8 women who's in menopause has a polyp in the uterus, which is not cancerous, hasn't bled. 1 out of 7 women has a cyst on an ovary, which is not precancerous, doesn't have to be dealt with. And if people don't appreciate that and you start looking at everybody with imaging, you're going to create a whole lot of unnecessary anxiety, more testing, and sometimes even, unfortunately, surgeries that are unnecessary. So we have to be responsible. Um, Actually, I was giving a lecture to a global audience on Zoom talking about these issues, and this young woman from Ireland on Zoom raised her hand and said, "Oh, we call those," because I call them incidental omas, and oma is a benign growth of incidental oma. I thought that was pretty cool. She said, "We call that vomit." I said, "What?" She said, "Yeah, vomit. Victim of modern imaging technology." So, because people now are doing, whole body MRIs, hoping they're going to pick up all these bad things earlier. You need to understand what's common and innocuous versus ominous.
Definitely. And I really appreciate how you've kind of centered your patients in that answer. Especially when training newer physicians and future doctors, they always think or they always feel the need to kind of use technology and, try different types of scans and imaging like for that patient. Not all, it could be a simple problem like coming in and the patient may not need, a whole MRI. And so I can actually relate to that. I had a whole MRI for a car accident that I was in last year, and the only thing that was truly paining me was my shoulder, and all I needed for that was a CT scan. So I was really like, I was in the hospital and they ran a whole MRI. So it's somewhat unnecessary to, be able to do the procedures that patients don't need. So, yeah.
I think also you have to understand there's a difference between having a finding on imaging and having a disease. And until people understand that, especially as you get much older, there are things that, there are things you're going to find that are not necessarily need to be dealt with and can be pretty scary to patients, depending also on how they're presented. And then people talk about doctors who practice very defensively. Some radiologists, if there's anything abnormal, it seems like the last line in the report is always malignancy cannot be excluded, and that's a ticket to the operating room. So you need to be careful when you start to look through a low power microscope at the entire body. You have to know what you might see and what's common and innocuous, as I've said 3 times now, and ominous.
Definitely. So, I'm going to edit this part up, but we only have 6 minutes left. So I know we want to, I want to ask you every single question there is. But if we do run out of time and you are mid-sentence, could you kind of like hop back onto the meeting so I could start re-recording it then and then kind of edit those clips together if you
Okay,
don't mind?
sure.
Okay, perfect. So writing some of the earliest textbooks in your field required vision and persistence. What was that like advocating for topics that weren't widely recognized at the time?
Um, well, actually, the very first textbook I wrote was kind of an interesting story. I was at the American Institute of Ultrasound and Medicine meeting, and I had a bunch of Polaroid pictures of different ultrasound scans. And a good friend of mine from the University of Arizona, who had just written a monograph, a tiny book on fetal echocardiography. That's babies' hearts in utero. She said she took me by the hand and took me on the exhibit floor to a little exhibit of a book group called Alan R. Liss that was housed in New York. And she said, I want you to meet my editor. And I met this woman and she said, so what do you work on? And I said, well, I do this vaginal ultrasound. She said, did you ever think of writing a book? And I said, well, I don't really have enough broad expertise to write a book. She said, well, no, if you write like half the chapters and have contributors for the others, that's still considered a single authored book. I said, really? She said, yeah, it's a long flight home. It was in Las Vegas. She said, it's a long flight home. You should think about a table of contents. So I actually did that. And I went and met with her and her people in New York. And I committed to writing this book and spent the next 6 months collecting images. And it's amazing. And an interesting thing is, once I had this hanging over my head, a deadline, it caused me to elevate my game in a way that I don't think I ever would have if I didn't have that deadline. But that was relatively easy, especially with this new technology. It was really that literary editor that got me interested and involved. And I wrote that book, and then that book had a second edition, and then I got involved with my friend from Columbia, and we worked on a book simply for gynecologic ultrasound because prior to that, most ultrasound was obstetrical. The reason that those great pictures of babies in utero look the way they do is fluid enhances sound transmission. And so a baby's in a bag of water. That's why you get those amazing baby pictures. In fact, sometimes we put a little saline, a little water into the uterus through a catheter. I've actually developed a catheter called the Goldstein catheter to put fluid into the uterus to see better. So fluid enhances sound transmission. But yeah, writing that book was not very difficult at all. Um, and then the layperson book that I wrote, the very first one called Could It Be Perimenopause, was 29 years ago, and nobody knew what perimenopause was. Nobody cared. But it was pitched very nicely by the literary agent. And in those days, you didn't have to have like a big following on social media, I think the way you'd have to today in order to get a book deal. And there were six publishing houses that bid on that book. And it was published by Little Brown. Never really made back what they paid me. And no one knew what perimenopause was. Nobody cared. Now it's huge, huge topic. When I was president of the Menopause Society for years, the membership hovered at about 2,000. This year it has surpassed 12,000 people. I mean, it's a huge topic. It's come out of the closet. Used to be a dirty word. If I was at a cocktail party when I was president of the Menopause Society and I told women who I was talking to that I was president of the Menopause Society, it cleared the room. It was a dirty word. It was associated with old and wrinkled. Today, it's just, people can't get enough. It's come out of the closet.
And writing a book, not only a book, but more than a book, more than one actually, takes a lot of courage and determination. So, congratulations again. And I love how you're just really fascinated about wanting to advocate for spaces and kind of changing, shapes in different fields and the motivation that you have to kind of push forward, even when that field, because I know you were mentioning it earlier, how that field wasn't ready to fully accept. I think it was something, I forgot what you were talking about. It was something that you mentioned, and then in 2009-ish, they actually implemented it. So I just love your,
Yeah. Well,
persistence and
and that's
determination.
that's the fact that change sometimes in medicine
Hmm.
moves at the speed of a glacier. And I didn't expect that when I made an observation in 1989 or another one in 1990, based on 26 patients, that they were going to change the standard of care. Those are called observational studies. The standard of care really didn't change until several thousand people were studied. But this was the first hypothesis of, wait a minute, this might be a different way of looking at things that I got credit for. But it took that long because once somebody like the American College of OBGYN puts it in one of their documents, it really becomes the letter of the law. There were many people who were practicing that way, even though it wasn't yet codified, if you get what I mean. Great.
So, so looking back, what accomplishments stand out to you as the most meaningful, either personally or professionally?
Uh, well, I'll stick with professionally. I mean, personally, I've been very fortunate to raise two great kids and uh, you know, I've had a good life, but I think there are a few things professionally that are probably worth mentioning. Um, I told you about that Ian Donald gold medal. That was really pretty special. Um, but there are two others that stand out in my mind. About maybe 6 or 8 years ago, I became an honorary fellow of the Royal College of Obstetricians and Gynecologists. So that's like Britain and all of the British Empire. Lots of societies have honorary fellows. In other words, I can't be a fellow because I'm not British. So, um, so I wasn't that surprised, when I was offered this and actually went to London and there was a ceremony with a cap and gown and the whole thing. But when I learned that since 1948, they'd only had 22 Americans who got this honor, and I looked at the list of names of people who'd gotten that honor, and I was blown away to be mentioned in the same company as those people. I think maybe they're still upset about the Revolutionary War, which is maybe why there were so few Americans since 1948. The other thing was there's a thing called Alpha Omega Alpha. I explain it by saying it's the equivalent of Phi Beta Kappa, but for medical school. So at graduation, the top 5% of the class graduating from NYU, from any school, will get into Alpha Omega Alpha. That's called AOA. So you graduate AOA. It's a big honor. Virtually all of my friends in medical school were AOA. I was not AOA. They don't really rank people. My guess is I was maybe in the 25th percentile from the top, not the top 5%. But every year at graduation, they take one faculty member into AOA for their accomplishments. And 25 years after I graduated from medical school at NYU, I got inducted into AOA as the lone faculty member. And that has always made me very, very proud.
Again, congratulations. I know I keep saying congratulations, and you're such an accomplished person, but I truly mean it. You're a great individual to look up to, and I'm so glad you were able to advocate for these spaces and be able to be a role model and a guide to so many countless medical students, professors, your family and stuff.
So
So,
I'm gonna interject here and I'm gonna add something. So the chairman of our department is a wonderful woman named Dana Gossett. And a couple of years ago, they had a session at the school about women in medicine. And she was one of the panelists. The head of pediatrics was a woman. There was a surgeon who was a woman. And they were talking about mentors and a little bit during their career. And Dana actually mentioned that every one of the people who had really been a mentor had been a man. Um, and I gave this a lot of thought, and I think that there's a difference between a mentor and a role model. I do think that sometimes a role model, at least in medicine, probably needs to be similar sex, whereas a mentor does not. And what I mean by that is, I think if you're a woman rising and you want to be academic or you want to be a certain type of physician, um, often if you're a woman, you'd look at a woman out there who's already done it, who's, let's say, juggled being a mom, being a wife, uh, and their medical career. That's a role model. But mentoring is different. Mentoring is different. And I'm very proud of the fact that I have mentored a number of people of different ages who different levels of success. Um, one of my other most proud moments, when I got that Ian Donald Gold Medal, it was actually at the World Congress of that society, and it was in Seoul, Korea that year. So I'm on a stage in Seoul in front of like 3,000 people, and the award is being presented by a guy from Britain who is at the time was president of the society. And as he's giving me this award, he relates a story. He said, and I don't even know if Steve, he called me Steve, Dr. Goldstein, remembers this. He said, but I was a fellow and just finished my training and was still in my fellowship. And I was presenting an abstract in San Antonio, Texas. And the session was being moderated by Professor Goldstein, he said. And you were so generous and so supportive of me. I've never forgotten that. And the irony is, I have no recollection of it whatsoever. But the fact that, and because he's as accomplished in his own right as I've ever been in mine and has risen through the ranks. But here he was at the very beginning of his career. There's another chap from Belgium, the University of Leuven, who has said a similar story, that I barely remember. So, and it's just nice to have kind of always given some counsel and advice to people, and the comment I'd make, and maybe it's good for some of your listeners, that sometimes when you're in a position and you're doing a really good job, people above you don't really help you or want you to advance because then they've got to fill that position. And I have never felt badly or not encouraged somebody to look elsewhere, to take a position that's going to be better for them, better for their family, better for their career, better pay. In other words, even if it means a loss to our our unit or our institution, in other words, it's a matter of not being selfish. I find that a lot of people who sometimes are in a position to support or promote, it's a form of selfishness because you've got somebody really good working in your team. You don't want to see them go. Whereas I have always had sort of a different philosophy, which is to do what's best for the individual rather than what might be best for my team, my individual, my institution.
Right. And lastly, to wrap things up, no, I know I've taken much of your time. I'm really sorry. What advice would you give to students or early career healthcare professionals who want to stay curious, ethical, and patient-centered in a rapidly evolving medical field?
Wow. I mean, I think the most important aspect is to never stop thinking, should always ask why. Where does that come from? What is the evidence? Too often people blindly follow uh, these clinical pathways, these algorithms, what the computer tells you. If A, we do this and B, we do that, as I've already alluded to. I think one of the most important traits that I try to encourage in the people that I encounter is to always be individualizing. It is not one size fits all. You don't want to treat people based on your own experience. That would be terrible. But by the same token, I think you have to synthesize that each case, it's not one size fits all. Each case is an individual. And the more you can use some judgment and experience in addition to evidence and, clinical guidelines, mesh these things together, is what can make you really good at what you do. Um, and then I guess the other thing is attitude. Attitude's 90% of life. I mean, it's like I'm in a good mood and I feel good about what I do until you give me a reason not to. And maybe that's just the way somebody's raised or not. But if you have a smile on your face and you have a good attitude, goes a really long way to making your life and everybody's life around you that much better.
Definitely. And thank you so much for sharing that advice and, all your contributions to science and medicine. And of course, thank you so much for sharing your journey, your wisdom, and of course, your incredible contributions to medicine. It's truly been an honor to have you on the show today.
And I'm going to say thank you to you. I'm impressed that you have taken this initiative to do this. This isn't the typical kind of thing that I participate in, but your persistence and your attitude is what got me to
Thank
do this.
you.
I had a really good time doing this, so I give
Thank
you
you.
credit and don't lose what you have got.
Thank you so much. It really means a lot. And your work has shaped entire fields and continues to influence how medicine is practiced today. Again, we're truly grateful that you joined us. To everyone tuning in, thank you so much for joining us on this episode of Battles and Voices. If you enjoy this conversation, then be sure to follow, share, and stay tuned for more episodes to come. We'll see you next time.